Доброго дня, шановні колеги. Я
Good
бачу,
afternoon, my dear colleagues, as I can see here. So our attendees keep joining. So let's wait up for still a little more time. So, and we will make a start, everyone who's joining. So please enjoy our webinar and enjoy the rest of the day. We are in the UPHC related webinar. Let's wait for all the participants to join.
Ще всіх вітаю. Я бачу, що
I would
кількість
like to
слухачів
extend my greetings to all the attendees, and more or less we have a sustainable count of our participants here. So let's make a start. Everyone enjoy the rest of your day. Just would like really to make it a point. So we are in the webinar of the main concepts and principles of antimicrobial therapy. So time-dependent and dose-dependent bactericidal and static antimicrobials, therapeutic and prophylactic application. Mr. Tibor, professor, who is from the microbiology school of Pécs University, Hungary, here with us, and he is research advisor to the reference lab of the Pharmacology Institute in Budapest, and he is chairing the AST National Committee. So he represents Hungarian-based ECOFF here. So this webinar is a follow-up of the tradition of the last year's cycle of the webinars launched. So the European introduction of antimicrobials administration and AMR practice perspective for Ukraine. So this cycle of webinars started out back in 2023. So the video recording can be retrieved in the YouTube channel, so made by the UPHC, and our announcements also uploaded on the Facebook page, so managed by the UPHC. So please keep track of it and keep your eyes open for the forthcoming announcements. I just would like really to say that we have our own partners here joining in. So US CDC, ICAP from the Columbia University, so that helps us with these events, and we have very well experienced lecturers, ex-med professionals who are the lecturers of these presentations, and our lecture will take for as long as 1 hour with the small section of questions and answers to be asked depending on the time, so we can still afford. So we have simultaneous interpretation. Please make sure that you stay in the Ukrainian channel. So then and there, so put yourself on the Ukrainian track, also stay in the English channel if you like. So Mr. Professor, can you turn the slide so we will have the guideline how to set simultaneous interpretation, please.
Дуже дякую. Так.
Thank you very much. So indeed, so here, so my dear colleagues, please set up your Ukrainian channel for the simultaneous. So we are in the wait of this fascinating lecture, and will be made by highly esteemed Professor Tibor. So the floor is all yours.
Thank you very much, Ignat. Do you hear me?
Yes, I can.
Okay, thank you. And first of all, I would like to thank the organizers for this honor to present today on the very basic concepts of antibiotics and antimicrobial therapy. The idea was that before the upcoming lectures, we all should be on the same page and just discuss some very basic principles of antibiotics. Some of this information might be new for you already. Some of them might be a little bit newer. All right, so by definition, antibiotics are natural products produced by bacteria or fungi, in fact, to fight each other in nature. And these are the compounds we isolate and use it for therapeutic purposes. In some cases, we don't use natural products, but we use antimicrobials, which are entirely made by chemistry. An example are sulfonamides. And also a large, probably nowadays the largest group is the so-called semi-synthetic antibiotics, where the natural product is further modified for better pharmacological features. Now, obviously, there is a large group, the so-called disinfectants. These are chemical compounds, but they are always used externally, but not to be mixed with topical antibiotics. Now, antibiotics are actually very unique compounds, very unique medicines. Actually, this is the only group which we give to a patient with the intention not to act upon the patient, but act upon a microorganism within a host, that is the patient. That's one point. And that means that whatever effect we see in the patient, that's a side effect, because we don't want to bother with the homeostasis of the host. The second thing, which is also unique to antibiotics, is that antibiotics may become less effective, that we call resistance, but that we see, let's say, with antihypertensive drugs or a variety of drugs, that they may lose efficacy once treating the patient. But antibiotics, the only one where this decreased efficacy can be transferred to another patient, that is, resistance does spread. And the third unique feature of antibiotics is that although we give the patient the antibiotic with an intention to act upon a particular pathogen, the antibiotic will act upon all microorganisms in the body, and often this has very severe consequences and side effects. Now, like for all drugs, we have a very important parameter that's called the therapeutic index, which is actually the TD50, that is the toxic dose, evoking a toxic effect in 50% of those exposed, and the effective dose, where actually in this case, where 50% of those given the drug, the infection is eliminated. Obviously, the higher this value, the safer the drug is, that is, the higher the difference between the toxic and the effective dose. Now, from practice, you know, a variety of side effects, just I list a few: ototoxicity, neurotoxicity, seizure, and so on. There are a variety of these side effects, but we have to keep in mind that there are effects, unwanted effects, which we usually don't consider side effects as such, like, let's say, impact of the normal flora, allergic reactions, and interactions with other drugs. That would be very difficult to calculate among side effects, but we have to anticipate those as well. Now, what is the clinical efficacy depends on? The clinical efficacy depends on, first of all, the susceptibility of the particular microorganism we want to eliminate from the host. But there are a number of other pharmacological parameters: the percentage of free and that is unbound drugs, and how the drug can penetrate into the particular tissues. And here there is a very broad variety. You know, again, from practice, that there are sites which are very difficult to penetrate, like the eye, the prostate, the bones, and the biofilms. And antibiotics vary greatly to what extent they can get into these sites. Also, a very important thing, that we have a few antibiotics which we administer as prodrug. That is, it's actually these are actually converted to an active form within the body, and that rate of conversion varies from individual to individual. A classical example could be, for instance, colistin. That's what makes the dosing of colistin quite difficult, because you give it as a prodrug. And of course, excretion of the drug, the site of excretion and the efficacy of excretion also varies a lot. Now, there is a concept, the spectrum of an antibiotic, which is often misinterpreted. Now, first of all, we do not have a very clear definition what we consider narrow or broad spectrum antibiotic. Nowadays, we even have some extended spectrum drugs, but roughly speaking, a narrow spectrum antibiotic is effective against a few gram-negative or a few gram-positive. A broader spectrum usually covers some organisms on both sides, a gram-negative and gram-positive, and obviously the extended spectrum has the widest spectrum. However, that's very important that when we talk about efficacy, it doesn't necessarily mean that an isolate belonging to a particular species is definitely susceptible, because the spectrum always refers to the natural resistance or natural susceptibility and not to the acquired resistance. So what is natural susceptibility? Natural susceptibility is the susceptibility which is characteristic to all members, and just as much natural resistance is characteristic to all members of a species, all strains or isolates. In the laboratory, we do not test natural resistance. It's known. There is no point to test, for instance, an E. coli for vancomycin resistance or Staphylococcus aureus for colistin resistance, because we know that they do have a natural resistance. They are not within the spectrum of these particular drugs. What is important to remember that if a species is naturally susceptible to an antibiotic, strains of the species can still be resistant due to acquired resistance. Give you an example. Klebsiella pneumoniae is naturally susceptible to colistin, but nowadays we see an increasing number of strains resistant to colistin due to acquired resistance, and laboratory always tests acquired resistance. Now, a few words about the mode of action of antibiotics. Let it be a gram-negative and a gram-positive cell. And one of the very common mode of action is interference with cell wall synthesis. Just think of beta-lactams, glycopeptides, phosphomycin, and so on. Then there is a large group which acts upon protein synthesis. We have a huge variety of antibiotics in this category. Aminoglycosides, tetracyclines, chloramphenicol, macrolides all belong to this group. Then a very important group, particularly quinolones, which interfere with DNA replication. And a smaller group, like rifampicin, interferes with RNA synthesis. Then the fifth one are drugs, particularly sulfonamides and trimethoprim, interfering with folic acid synthesis, and an increasing group of the so-called membrane active agents like colistin, polymyxin, for instance. So these are the basic mechanisms of the currently used antibiotics. In the pipeline, there are some antibiotics which hasn't reached clinical practice yet, which might have alternative modes of action. A very important feature of antibiotics, whether they are cidal or static, that is, they are bactericidal or bacteriostatic. Obviously, cidal means that they kill bacteria, static means that they prevent their growth. However, there is no clear definition because between the two, because let us not forget that this categorization is based on in vitro measurements under strictly controlled condition with a relatively low inoculum size, that is 5 times 10 to the 5 colony-forming units per mil, which can be much higher, actually, within the host, within the patient. Then we choose an artificial threshold for killing, and we say it's bactericidal if it kills 99.9% of the bacteria exposed. And it can also be concentration dependent. That is, in a lower concentration, a drug against a particular microorganism can be static, but if you increase the concentration, it can reach a cidal concentration. And of course, it's definitely species dependent. There are some antibiotics which in one species static, while in other species it's cidal. Now, in practice, in the laboratory practice, we measure the minimum inhibitory concentration, that is the MIC. That means that what is the lowest concentration of a drug against a particular isolate which inhibits the growth. Now, one may ask that, don't we want to know how much drug we need to kill the organism? For general purposes, in the overwhelming majority of the cases, we do not need that. So the laboratory susceptibility testing is based on measuring directly or indirectly this minimum inhibitory concentration, right? Upon special request, laboratories can test the minimum bactericidal concentration, but that's much more complicated, and usually we do not need it in the everyday clinical practice. Now, also a point where there are common misunderstandings how resistance develops. An important statement we have to make that antibiotics are not needed to develop resistance. The development of acquired resistance is a very rare phenomenon, but we don't need the presence of antibiotics this to happen. Let me just use this example that if we have two cells, one which is susceptible and one which is resistant, and resistance is here symbolized, this burden of a small boat, it means that if there is no antibiotic in the environment, this cell, this individual can be heavily burdened by becoming resistant, because in the middle of the desert, it doesn't provide any advantage. And it may happen that actually cells becoming resistant spontaneously by a mutation, for instance, even won't survive. Now, everything is changing when all of a sudden antibiotics are present, because in the very moment, actually, the cells which became resistant spontaneously has the advantage. Going back to our little fellows, the one who has the boat, now it doesn't have to carry it, but it is an advantage of having a boat in the sea of antibiotics, while the susceptible one will suffocate and drown. So that means that what antibiotics are needed for is the spread, the maintenance of resistant cells, and they actually facilitate the spread of antibiotic resistance. Now, let us see how a cell can become resistant. To understand the mechanisms, let's take this example. Let's suppose that there is a physiological process in the bacterial cell, X becoming Y, and that is catalyzed by this molecule, this green molecule. Okay, obviously, in order to survive or to multiply, this reaction has to take place. Now, if you have an antibiotic which interferes with this process and X cannot become Y, either the cell stops multiplying if it's a static antibiotic, or even die if it's a cidal antibiotic. And in that case, the cell is susceptible to this antibiotic because the antibiotic does the job and kills or stops the cell from multiplying. However, resistance means that this antibiotic, what we provide, cannot do the job. That is, X becomes Y, the cell is happily living and multiplying. So that's resistance. Now let's see how this can be achieved. The first mechanism is a well-known mechanism that the bacterium starts producing an enzyme which actually destroys the antibiotic, and the antibiotic cannot prevent this reaction to go on. The second, and just an example for the first one, just think of ESBLs or carbapenemases. These are very common antibiotic splitting molecules. The second mechanism is when this target molecule changes a little bit. It changes a little bit, therefore the antibiotic cannot bind any longer, so it cannot prevent its action. Again, X becomes Y, the cell lives continuously. An example, MRSA. The penicillin binding proteins becomes modifies a little bit, so beta-lactams cannot bind any longer. The third mechanism is when the uptake of the antibiotic by the bacterial cell is limited. Classical example, mutations of the porin channels in the gram-negative cell wall, they become less or they modify, so the antibiotic cannot pass through. Pretty much the opposite of this is that if the antibiotic enters the cell, but there are mechanisms pumping out in large quantities the antibiotic, these are the so-called efflux pumps. The problem with those is that often they are not very specific to a particular antibiotic, so multiple types of antibiotics can be pumped out, leading to multi-drug resistance. The fifth mechanism, the bacterium starts producing a shield, which is actually protecting this effector molecule, so the antibiotic will not have access to the target. An example are the QNR resistance mechanisms for quinolones, or in some cases, tetracycline resistance can develop in this way. Then the sixth mechanism is when the cell produces a lot of this target molecule. The antibiotic can bind to it, but certainly not enough antibiotics are present to interfere with all molecules produced. So simply this overproduction allows the reaction to take place. And finally, the cell, the bacterial cell, develops an alternative mechanism. So, well, the antibiotics blocks this X to Y mechanism, but Y can be reached in an alternative way. And sometimes we see it with trimethoprim resistance. So how does resistance spread? From clinical practice, we all know that probably the most obvious way is that resistant bacteria spread from one patient to the other. It's very common, causes a lot of problem, but the good news is that this is the easiest to deal with, because simply we just have to isolate the patients or prevent the strains from spreading with good infection control. However, there is another way, and actually that we call horizontal gene transfer, when resistance genes, usually via plasmids, spread from one cell to another. That leads to something we call plasmid epidemiology. It's not the same clone is spreading in a hospital, but plasmids spreading from one species to another, converting them to resistant. And the third mechanism is the so-called jumping genes. Transposons can actually jump within the cell, within the bacterial cell, from plasmids to chromosome and to other mobile elements, and that is often called the integron epidemiology. Now, what you see in your wards is the mixture of the three. The problem is that, as we said, you can interfere with this by good infection control, but to this, basically the best way is antimicrobial stewardship, limiting the load of antibiotics, limiting the capacity of antibiotics to give advantage to strains becoming resistant. Now, a few words about pharmacokinetics and pharmacodynamics. Roughly speaking, and I hope that the pharmacologists won't take it wrong from me simplifying this so much, pharmacokinetics is usually what the body does to the drug, but pharmacodynamics is what the drug does to the microorganisms. Now, both has different parameters. For pharmacokinetics, obviously, body clearance, volume distribution, protein binding, bioavailability, while the most important parameter is for pharmacodynamic is the aforementioned MIC, minimum inhibitory concentration. Now, if you integrate these two, this allows us to understand better how different antibiotics work. Now, this is a very simple dose-response curve. So basically, you give the antibiotic, the concentration in the plasma goes up, and after a while, it comes down. This dotted line is the minimal inhibitory concentration of the particular isolate we have to investigate to what extent is it susceptible to. Now, there are three important parameters, so-called PK/PD, pharmacokinetic, pharmacodynamic indexes. The first one is the Cmax, the maximum concentration you can reach in the plasma by dosing an antibiotic. Okay, and the parameter is that how this maximum concentration relates to the MIC of the particular isolate. Obviously, the higher the better. The larger the difference between these two concentrations is, the better. The second one is when we relate the time above MIC. So that's the time what the concentration spans over the MIC of a particular strain. That is, obviously, the longer this time, the more efficacious certain antibiotics are. And the last one is basically a mixture of the two, where the entire so-called AUC, area under the curve, is compared to the MIC. Now, the important point is that the efficacy of different antibiotics can be related to different parameters. To give you an example, usually aminoglycosides, fluoroquinolones, polymyxins mostly relate to what is the maximum concentration you can reach. So what matters is that you want to have as high concentration in the plasma as possible. On the other hand, so these are so-called concentration-dependent antibiotics. On the other hand, most beta-lactams, particularly carbapenems, are more related to the time, how long the time is over the MIC in this curve. It doesn't really matter how much above the MIC. It should just be above the MIC, maybe the 2 MIC, but what matters is that how long it will take. And finally, glycopeptides, particularly vancomycin, is mostly related to this area under the curve compared to the MIC value. So these are the time-dependent, concentration-dependent, and we can say AUC-dependent antibiotics. There is an interesting effect, what we call post-antibiotic effect, that describes what happens after the cells are not exposed any longer to the minimal inhibitory concentration of a drug. Let us see this graph. Here, this is a simple growth curve. So this is the MIC value. If the bacterium is above the MIC, it will grow, and after a certain while, it will reach a 10 times increase. Now, if this is the antibiotic, here you don't have antibiotic. Here, this is the antibiotic, and the bacterium will start growing if the antibiotic concentration curves hits the level below the MIC. Before that, it will prevent growth, right? Now, this is what you would normally anticipate. But certain antibiotics and certain, in case of certain organisms, have something we call the post-antibiotic effect. That is, the concentration of the antibiotic has already decreased below the MIC, but the bacterium still will not start growing for a while. This, while it still hasn't started growing, this is the so-called post-antibiotic effect. That is good for us because although the concentration of the drug is below the MIC, the bug still hasn't started regrowing. So that actually works for our curative purposes. We don't entirely understand the mechanism, and here I don't want to read this for you one by one, but basically there are a number of theories. What is important is that not all antibiotics has this post-antibiotic effect. Usually carbapenems with gram-negatives do, and that actually we can utilize that. Let me put it in this way. It works for us. It works for the patient. And you may come across with this term when talking about antibiotics, that it has a good or it doesn't have a post-antibiotic effect. All right. Now, a few words about how the laboratory helps you with data on antimicrobial susceptibility. First of all, let me start by saying that we face here a huge problem because we in the laboratory do this. That is, we expose bacteria, the patient, the one isolated from a patient, we expose this strains to different antibiotics in an enormously simple system, in a Petri dish or in a tube. That's a very, very simple system compared that based on these results, we try to predict what is going to happen between the same bacterium and the same antibiotic in an immensely complex system that is your patient, right? So the problem is that from this very simple system, we should make predictions whether the strain is susceptible or resistant. And obviously, these predictions are based on certain guidelines. Now, in Europe, we use the ECOFF, the European Committee of Antimicrobial Susceptibility Testing guidelines. And basically, this is how it looks like, that we already defined the minimal inhibitory concentration. And then we have a very, very important term, the clinical breakpoint. The clinical breakpoint is a threshold value established by a committee, a threshold MIC value, which distinguishes between strains which would react in vivo to the treatment, we call them susceptible, those which have such a high MIC that it's unlikely that they would actually be eliminated by the drug. So that's a clinical breakpoint. And that's a very, very important term. And UCOST in the US CLSI determines for the most important pathogens and for a number of antibiotics, pretty much all antibiotics, these breakpoint values, either in MIC or also in zone diameter, if the laboratory is using this Kirby-Bauer technique using antibiotic-containing discs. So basically, these are the guides helping the laboratory how we communicate the results to you. Now, this interpretation based on the clinical breakpoint has changed dramatically in the past few years. Earlier, we had 3 categories, and we wrote to you, physicians, that the strain is susceptible if using the drug, there is a reasonable chance for therapeutic success. The other end was resistant, that the MIC was so high that it's very unlikely that this drug will work in the patient. And we had this very dubious intermediate term with uncertain therapeutic effect, which was very, very difficult to define. Now, that has changed in 2019, and the first two categories stayed, but the middle one, instead of intermediate, we call it now susceptible with increased exposure. That's a fundamental difference, because susceptible means that the strain is susceptible if you apply normal dosing, I would say, rather normal exposure. But there are strains which still can be susceptible if you can increase exposure. Increasing exposure might mean that you can use a higher dose, you can give a more frequent dose, you can, for instance, in case of carbapenems with time-dependent antibiotics, you can apply them for a more extended period of time. So these are all susceptible with increased exposure. So graphically, that was the old system. So you had the susceptible, you had the intermediate, and you had the resistant. Now in the new system, and I'm sure that your laboratories are releasing the results as such, both these groups are susceptible, but the first group is normal dosing, normal exposure. The middle is still susceptible with increased exposure. That's a very important change. Now, I'm sure there are some microbiologists in the audience as well, and often we run into the problem that, okay, we can use this clinical breakpoint to interpret the results for you, but clinical breakpoints are not necessarily available for all microorganism antibiotic pairs. Simply, the ECOFF does not have enough data to come up with a clinical breakpoint. What can we do then? And actually, you physicians may run into such communication from your laboratory. One possibility is that recently ECOFF released a guideline for this particular problem. We don't have breakpoints, so we cannot specifically tell whether it's susceptible or not. Then they released tables referring to the different MICs, what you measure, what the laboratory measures with the strain for gram-negative and gram-positive bacteria. You can see that the list here of antibiotic list is very short, relatively short, so these are not available for all antibiotics, and we don't deal here with species. We deal only with gram-positive, gram-negative organisms. So the bottom line is that your laboratory can easily run into the problem with certain isolates that, hey, we don't have a clinical breakpoint. We cannot interpret the results as we usually do. What can we do then? First of all, then the laboratory will not release the data as susceptible, intermediate, or resistant. What the laboratory can do, if the MIC is, let me go back, above this threshold, then if it's above, the laboratory may just tell you that formal categorizing the susceptibility of the organism is not possible, but the MITS value suggests that it's probably unsuitable for therapy. Of course, if it's below, then again, a cautious note can be released that we cannot say it's susceptible, but cautious interpretation may suggest that with that low MIC, it still can be considered for therapy. Please remember that this is important when you have no alternatives, when all the classical drugs are gone because the organism is resistant. So actually, nowadays, we are increasingly running into this problem. Well, we said that, unfortunately, this list of antibiotics, what I showed you in the previous table, is relatively short. So what else can we do? Then we can turn to the so-called epidemiological breakpoint, or ECOFF. It's an often used term nowadays, and ECOFF is separating the so-called wild-type strains from the strains which are non-wild type, which have acquired some resistance mechanisms. what you can see here on this graph, here are the different MICs, and here are the percentages of the large number of strains tested. And here you can see, and ECOFF really tests hundreds and hundreds and thousands of strains from all over the world. And then they graphically put this together, saying that, let's say, the majority of the strains of this particular species, that's E. coli with ciprofloxacin, had this MIC value, and so on. But a few strains had higher MIC, and these are the ones which are having some kind of resistance mechanisms. The line separating the two is the ECOFF value. That is, in this case, I guess, 0.6, separating the wild type from the ones which have some resistance mechanisms. Actually, this is in a table form E. coli, let's see, amikacin, and here you see the number of strains, and these are all susceptible with different MICs, and then these strains with some resistance mechanisms have higher MICs. So the ECOFF value is 8. So if we don't have anything else in the lab, we can actually turn to the ECOFF and tell to you that, well, I cannot interpret the results based on the traditional way, but your strain from your patient is a non-wild type strain. It seems to have some resistance mechanism. The use of this particular drug is not likely to lead to a clinical cure, while if it's a wild type strain, it seems that the strain does not have any resistance mechanism, and cautious interpretation suggests that it might be considered for therapy. Obviously, as a physician, you try to use antibiotics where the laboratory can clearly tell you susceptible or resistant. But again, we are increasingly running into, with the multi-drug resistant organisms, into this problem that it's not all the time the case. Now, there was another possibility, and although it's not recommended any longer, you may still hear that the interpretation is based on the pharmacokinetic, pharmacodynamic breakpoints. In the past few years, EUCAS does not recommend to use it, but just very, very briefly, again, still some laboratories are using it, so just to be familiar with the concept. Remember, we said that there are drugs which are time-dependent. For instance, let's take penicillin, okay? And we like to give a dose when the concentration is at least 50–60% of the time is above MIC. Or let's take aminoglycosides. Aminoglycosides is a concentration-dependent drug, and we like to have the concentration of the drug at least 10 times higher than the MIC. But please understand that everything depends on the actual strain's minimal inhibitory concentration value. And basically, you can set a kind of a breakpoint on that basis by saying that, let's see the MIC of the isolate. What is the chance that I can reach this target? And if the MIC is low enough to reach the target by 90% probability, we can call it as a PK/PD breakpoint. You can use it. If the strain, let's say, has a 4 MIC, obviously here the chances to reach that target is much lower, 80%. Don't use it. Once again, this method is not recommended any longer, but still some laboratories do, and I just thought that the concept I should briefly mention. On the last part, how do we apply antibiotics? You know much better. The classical way is that we apply antibiotics for therapy. That is, we have a healthy person who got exposed to a microorganism, becomes sick, visits the doctor, and we give the antibiotic. That's the classical scenario. No problem here. Well, there are some problems. We'll come back to this. The second is prophylaxis. That's a little bit more tricky because either we want to prevent an infection with an anticipated imminent, which can be due to an anticipated imminent exposure, or there is a situation when we think that an exposure was possible. The patient still doesn't show any symptoms, but we better provide some antibiotics. Just think of a Neisseria meningitis outbreak, and the close so-called kissing contacts are usually given some antibiotic prophylaxis. Important, this should be used very sparingly, so it definitely should not be overused. The other one, where we actually have an imminent exposure, think of surgical prophylaxis. Those among you who are surgeons know very well that in most cases, in most surgeries, depending on the type of surgery, but most often we use second-generation cephalosporin, cefazolin, for instance, not longer than 120 minutes before the first cut is being made, just to prevent surgical site infections. So that's prophylaxis. Now, then comes decontamination. Now, that's a tricky one. Decontamination is that we have someone who may not even show any signs of infection, but we know that he or she is colonized, carrying an organism. And obviously, we want to eliminate this organism for the purpose of preventing it to serve as a source of an later endogenous infection, let's say before a surgery or some medical procedures. Well, that's easier to say than done. In some cases, it's easier. I'm sure you're familiar that, for instance, MRSA is very often carried in the nose, in the nares, and we can easily try to eliminate MRSA by applying mupirocin ointment. Let's say before a surgery, you don't want MRSA to be an infectious agent there. Also, skin surface. If the patient carries, let's say with MRSA, chlorhexidine bath could be very useful in kind of a decontaminating the patient. The major problem is the intestinal tract. If the patient is carrying some multi-resistant organism before entering certain wards, let's say a hematology ward, or coming from bone marrow transplantation, or nowadays, for instance, even an everyday problem is that if the patient has to go to a prostate biopsy through the gut wall, there were cases, where ESBL got into the bloodstream and so on. The problem here is that eliminating microorganisms, particularly resistant ones from the gut, is very, very, very difficult. I would say near impossible. Why? Because obviously you should use very broad spectrum antibiotics to do that. But then you risk all the severe consequences of using broad spectrum antibiotics, and you may not want to risk, let's say, C. diff, a Clostridioides difficile infection to develop. So right now, we don't really have a clear standing on how do we eliminate multi-resistant organisms from the gut. Well, there are interesting publications like phage therapy, bacteriophage therapy could be one, but it's certainly far from being used broadly in clinical practice. So decontamination in some situations is fairly straightforward, skin, nares, nose, but gut is a very, very difficult question. Then let's talk about therapy. As you know from your own practice, we have two kinds of antimicrobial therapy. empiric and definite or targeted antimicrobial therapy. Empiric is that when you see the patient, you took a sample, send it to the laboratory, but before getting back the results, often you have to initiate the therapy because you have no time to wait. The patient is there and suffering. Definite therapy, what you administer while knowing the specific results, that what is the pathogen and what is its susceptibility. Empiric therapy, we like to call it a gray zone. It's always based on guesses. You got to guess the most likely organisms and the most likely susceptibilities of the predicted organisms. But these are all assumptions. Okay, so that is the two kinds of antimicrobial therapy. Why is it so important? Well, everything depends on the spectrum of the drugs you use. You may recall we discussed narrow and broad spectrum antibiotics, and a few years ago, the WHO came up with this very important categorization of drugs. You have the excess drugs, which are usually the narrowest spectrum drugs with the lowest resistance potential. You have the so-called watch drugs, which we like to use very sparingly. And then you have the reserve, the very last resort, drugs reserved really for life-threatening situations for MDR. Now, the point is that what the European Union wants is that the excess drugs should represent at least 65% of all antibiotics we use. I don't have the data from Ukraine, but I have the sad data from my own country, and we are way below this 65%. So we use more antibiotics in the watch group than actually we should. There are some countries which do much better than us. I bet, although I don't have the statistics, that usually, I guess, that Ukraine in your country is also shifted towards this watch group compared to the access group. And this is when it's so important to know that how do you do with the empiric and the targeted therapy. Okay, let's see two cases or fictive cases. Empiric therapy, again, we don't know anything about the agent, we just can guess, and we don't know anything about the susceptibility. Now, obviously, you have two ways to go. If the case is not a severe case, not a life-threatening case, let's say an ordinary urinary tract infection or an upper respiratory tract infection, we should start with a narrower spectrum antibiotics. And here, again, I'm talking about Hungarian experiences. Often there are mistakes being made. In an ordinary urinary tract infection, a cystitis, uncomplicated cystitis in a non-pregnant woman, we should not use ciprofloxacin or amoxicillin clavulanic acid. They are too broad spectrum, and the most likely pathogen, E. coli, is likely to be susceptible to narrower spectrum drugs like fosfomycin, Vigramon, and so on. Can the patient be unlucky and being infected with a resistant organism? Oh, yes. But this is the risk we still should take because it's a simple cystitis. Worst case scenario, the patient comes back 2 days later that I haven't improved. I mean, his or her condition will not deteriorate that fast that we cannot take that risk. Now, the story is totally different if you have a very severely ill patient, let's say a meningitis patient or a septic patient. There, you cannot take that risk because that patient can die within a few hours' time. So you have to start your empiric therapy with a much broader antibiotic just to be on the safe side. So that is how we can limit the overuse of broad spectrum. Use only when it's absolutely necessary. What can we do if we actually know the pathogen? What can we do with empiric therapy? So serious patient, we started with a broad spectrum therapy. Laboratory results comes back that indeed the organism is a multi-resistant organism. In this case, if the result tells you that you have to change or maintain the broad spectrum coverage. But what if the result comes back that, okay, you rightly anticipated a resistant organism, but this patient is lucky, it's a susceptible organism. And this is when we de-escalate, or we should rather de-escalate the therapy. That is coming back to a narrower spectrum. Let me give you an example. You have a patient, a severely infected patient in grave conditions where, for different reasons, you anticipate MRSA. Obviously, you have to give a broad coverage, most likely vancomycin. And if the result comes back that indeed this is MRSA, continue. But if it comes back that this is not an MRSA, then you definitely should de-escalate to a narrower spectrum drug, let's say a second generation cephalosporin or an anti-staphylococcal penicillin, flucloxacillin, or something like that. The therapeutic effect is just the same, but not a broad spectrum. You narrowed the spectrum, you de-escalate it. Well, the problem is that de-escalation is certainly not applied as much as it should. Again, I can show you the European data, and there this odd greenish, yellowish thing means that how often we use de-escalation, and unfortunately not that often. And again, some other countries do much better than us, but that's very important, again, to lower the spectrum, narrowing the spectrum of drugs we use, because again, remember that facilitates the spread of resistant organisms. And on my last slide, what is the role of the laboratory in all of this? Well, we have two possibilities to interfere. One, during the empiric therapy, we should provide preliminary data as soon as possible. Again, I'm sure that you physicians have often been in the situation when initially you have no clue what the infective organism is, but after a gram stain, the laboratory calls you that, look, I don't know what that is, but it's gram positive. That actually can be a very useful piece of information. Or in case of a meningitis, after tapping the CSF, cerebrospinal fluid, and the laboratory in an hour phones you that, well, I detected, let's say, pneumococcus antigens in the CSF. That's not a final result, but can be very useful and very quick. Of course, if PCR is available nowadays, we have excellent multiplex PCRs covering the most common organisms in different types of infections, and that can also be very useful. Usually they are ready in 2-3 hours. How can we help the definite therapy? Well, most of all, shortening the time you are in the gray zone with your empiric therapy. And then there are nowadays some techniques. I don't know whether how widespread is the so-called MALDI-TOF, which is a mass spectral identification system. It actually saves 1 day in identifying the microorganisms. And there are some techniques, for instance, in blood culture, the rapid antimicrobial susceptibility testing also can actually shorten this time. So basically, that was my presentation, what I wanted to cover the most important concepts, and hopefully this will be helpful later on when my colleagues will come and give you lectures on specific topics. So with that, with the area view of my city, let me thank you very, very much for your attention and for this kind invitation to be part of this important project. Thank you very much.
Дуже дякую, професоре
Thank you
Тіборе.
very much indeed. So, Professor Tibor, so very interesting presentation. So you've just really made it all plausible. And the last but not least slide, a practical hands-on recommendation for us to use, because an interaction between the clinician and the clinical pharmacist and the microbiologist really ensures success of the patient's therapy. Whenever we are talking about these small techniques, so microscopy or really gram staining will help you so to do so much improved and much quicker to do your empiric therapy. Well, colleagues, once again, so we've had a very busy presentation and the lecture alike, and bearing in mind our time. So let us check out if you have any questions to ask for Tibor, Professor Tibor, so to get him to answer a couple of our questions, please. So the immediate question. So this lecture, as all of the previous lectures before, so shall be in recording, and in a few days it will be uploaded to the UPHC website for you really to check out and retrieve the materials once again and get access to the previous recordings. Please sign up for the UPHC Facebook page to keep abreast of the forthcoming announcements and taking advantage of the situations whilst the colleagues busy asking questions. I'm ready with my own question, please. The question is all about the facts. So you're talking about the aware classification. Unfortunately, the ECDC data, we don't have the excess consumption antimicrobials improving year in, year out. 47% now, excess group, but our separate reserve group antimicrobials consumption pretty high as compared to the values in the other countries. What is your tip and advice? So for the rationale of the reserve agent choice, what is the hard and fast criterion for us really to do the reserve? What is the laboratory criteria and what is the patient condition? So a good reason for it, please.
Well, first of all, we should remember that in most countries, the antibiotic consumption in human medicine is 90%, about 90% is for outpatients. It is surprising because we are always focusing on hospitals, but overwhelming majority of antibiotic use is in outpatient settings, not in the hospitals. For a Hungarian, this is particularly bad news because we are way the worst in Europe using broad-spectrum antibiotics in our outpatients. So, I mean, what we are trying to do, with not much success yet, is actually to educate family physicians, how to initially treat everyday infections. And I just brought up this example of an uncomplicated cystitis. And fluoroquinolones or beta-lactams with a beta-lactam inhibitor, while used very frequently, they should not be. We have excellent drugs like fosfomycin, nitrofurantoin, and so on, sulfonamides, which actually could work. That's one thing. The other thing is that in the hospitals, wherever it's possible, one should establish antimicrobial stewardship teams. Antimicrobial stewardship teams, which includes ID physicians, microbiologists, and very importantly, which should include the clinical pharmacist. Because we don't like to admit, but nowadays in the hospitals, particularly with complicated cases, antimicrobial therapy became so complex that only this team can have the answer, the right answer, how to dose antibiotics. For instance, it was our experience in in Pécs at this university hospital that introducing the measurement of vancomycin, glycopeptide, and aminoglycoside concentration in patients changed therapy, because we either underdosed or overdosed that. So all of these things actually can help and colleagues to find the right antibiotics and the right dosing regimen. Now, what the lab can do is be as quick as possible. Be as quick as possible. And with antimicrobial susceptibility testing, there are some great possibilities for blood cultures now. That's called the RUST method, the rapid antimicrobial susceptibility testing, because you know that if a blood culture becomes positive, usually first we cultured the organism and then next day we did the testing. Now with this RUST method, you can actually do a preliminary susceptibility testing for quite a few organisms straight out of the bottle. That saves you 1 day. Again, you can be sooner at the definite therapy. So I don't know whether I answered your question, if I got it right or...
Дуже дякую за
Thank
таку
you very much
відповідь.
for this very extensive answer. So a lot of useful information inside, as I can see. So the colleagues now sharing a lot of questions for you to ask. Let us do the questions here now, because we are really running out of time, so we won't be able to follow up on all of these questions asked. So let's do the questions here now. So the question is, how do you make use of the PCR? So prior that the laboratory turns you around the microbiological assay results.
Well, currently what PCR can be used is to identify the organism. To some extent, we have multiplex PCR systems which would target certain antimicrobial resistance genes as well. Give you an example. There are the so-called syndrome-based multiplex PCRs. So let's say lower respiratory tract infection, the sample comes in, and we have PCR system testing for the maybe 15, 20 most common pathogens causing lower respiratory tract infections, which is including both bacteria as well as viruses. But for the bacteria, in the panel, there are also some resistance genes targeted as well. Okay, carbophenamases, for instance, or some ESBLs. So within 2 hours, 3 hours, you can have a result that, okay, it's Klebsiella positive, and let's say a carbophenamase positive. Okay, important to remember that right now, susceptibility is based on phenotypic testing. It's a phenotypic phenomenon. Testing for resistance genes can be very useful, but it's usually doesn't give you the final susceptibility data. But obviously, I mean, if your PCR detects MRSA, okay, it's clear that you are not going to start with the beta-lactam. Okay, so but right now PCR is more for the identification, the detection of particular microorganisms. Since the COVID, what we have been using very extensively is the syndrome-based multiplex PCR covering some 25 pathogens. We also have it for central nervous system infections. And again, within 2-3 hours, in the middle of the night, you can have some ideas of the pathogen. Now, for antimicrobial resistance, probably using PCR, probably the best example is the Mycobacterium tuberculosis multiplex PCR, which simultaneously with the organism can detect 2 resistance genes. So even within a couple of hours, you know that this is a multi-resistant TB or not.
Дуже дякую за відповідь.
Thank you very much for your answer. And the next question really hands-on. So the answer is really, so which antimicrobials are prescribed empirically in case of abdominal infection in Hungary, please?
Oh, well, okay. Well, obviously, in case of an abdominal infection, you have to anticipate basically half of the textbook, because you know it's usually coming from the gut. So you definitely have to give a very broad coverage, which is definitely should include coverage for anaerobes as well. So hospital, and again, what kind of intra-abdominal infections depends on, but there I would not hesitate to be very, very broad spectrum. Certainly carbapenems, probably with some aminoglycosides and metronidazole. I mean, again, it depends on the case that how that intra-abdominal, but there is no room to start with a narrow spectrum.
Дуже дякую за відповідь, пане
Thank you very much
Соколович.
indeed for your answer. I'm in full agreement. So depending on the case, it is, yeah.
One more case. Unfortunately, I forgot to put my email address on the slides. But please, Ignat, you have my email address, right? Please share the email address at any time.
Yes, I have.
If somebody has some questions, don't hesitate to send me an email, and I definitely will answer and send you some materials. Yes, please go ahead.
Так, добре.
Well, indeed so. Sounds good. Let us do the next question. So we are getting more and more questions in, but let us take another one or two, and we will allow you really to be in email correspondence with our colleagues. So the next question, and the next one really hands-on and practical, very typical for Ukraine to ask. So we have the consequence whenever transferring the patient on the antimicrobial therapy, so from GP setting into the hospital. So and the clinicians wonder, so if the patient really is broad spectrum antibiotic, ceftriaxone, the patient has been exposed to. So what is the strategy? So if it is really broad spectrum and now already resistant, what to do up next in the hospital setting?
Well, again, I mean, I don't want to avoid the question. Again, depends on the case, depends on what kind of infection are we facing. I mean, if it's ceftriaxone resistant, well, it means that cephalosporins are likely to be out. Okay, so then, you know, with, let's say, a bloodstream infection, empirically, well, then you have that, again, depends on the case, because then you have options of using this newer beta-lactamase inhibitor combinations. Let's suppose it's ceftriaxone resistant because of an ASBL. Then ceftazidime avibactam could be a player. We are not very happy of overusing ceftazidime avibactam for ASBL producers, but in a life-threatening situation, that could be a possibility. Of course, alternative could be carbapenems. But also, let us not forget that the third generation cephalosporin resistance doesn't mean necessarily that other antibiotics, narrower spectrum antibiotics, are necessarily out. So, I mean, a good microbiology laboratory testing would actually tell you that it's still susceptible to fluoroquinolones. It's still susceptible, not very often though, I agree, still could be susceptible to sulfonamides and so on. But again, if it's a severe case and the patient is just being transferred and you know that it's positive for a third generation cephalosporin resistance, then it's getting to be tricky, because again, carbapenems, again, beta-lactamase inhibitors, this is what I would consider empirically before knowing the results. Now, as you mentioned that, if I got the question right, ceftriaxone resistance from an outpatient. It is possible, and in some countries we see some alarming signs that ceftriaxone is often used in outpatient clinics. Even for cases, I used to work in the Middle East for quite a long time, and there, for instance, ceftriaxone was frequently used to treat sore throat, which is an absolute nonsense. But I mean, I know that sometimes it happens in other countries as well, and that is absolutely a no-no.
Thank you very much for your answer. Once again, I'm in full agreement with what you've said. It is a certain prejudice to say that you have a resistance to broad-spectrum antimicrobials. So by default, you exclude possible susceptibility to narrower spectrum antimicrobials of a different group, but you should get really the microbiology findings, express tests, rapid tests, and microscopy. So in the count of hours, so will be a major relief for you. So, and I just would like really to acknowledge here as well that our ICAP colleagues have shared the email of Professor Tibor, so that a highly esteemed professor has asked doing so. Please, so keep it for further correspondence, and also bearing in mind the time constraints. So we will have to call it a day, and then, and actually, after really looking all the other questions across the board, so it relates to some very specific questions in relation to the Ukrainian legislation, and I think that our highly esteemed professor won't be able really to give an answer because he is very much drawing upon the Hungarian legislation for that matter. Thank you very much indeed, so highly esteemed Professor Tibor, for very meaningful answers, because you've managed really to take a lot of questions to be answered. And I think that after this information digest, so please look out for more incoming emails. And thank you very much for the lecture. Thank you very much, so attendees, for joining. So please keep an eye for further announcements to be made.
Thank you very much. And once again, thank you for inviting me. And from the bottom of my heart, I wish you all the best in Ukraine. Thank you.